Good afternoon, ladies and gentlemen. I'll invite our panelists as speakers to come up and join us. Good afternoon. Welcome to the Woodrow Wilson Center. My name is Jeff DeBelco. I have the good fortune of hosting and chairing today's session. I'm the Director of the Environmental Change and Security Program and the Coordinator of the Global Health Initiative, and it is our distinct pleasure to be working with CEDPA on today's event in the Maternal Health Series, a series that we have as regular partners and supporters, the Maternal Health Task Force, UNFPA, and with some additional support and technical assistance from USAID's Bureau of Global Health, a lot of partners to bring together today's discussion of what is obviously a critically important topic, but one that doesn't get as much attention as it should, given the challenges that are presented in family planning in fragile states, overcoming cultural and financial barriers. We have what I think is a real treat, a real opportunity to hear from some practitioners in very different contexts, battling some of the same issues, and then as we'll hear some of the differences among them, but really some from the field, literally within the last days and weeks, folks working on these issues in some really tough neighborhoods in terms of the additional challenges that being in conflict settings presents for addressing family planning and maternal health issues. I want to say right up front to welcome to those who are watching online as well. You can email your questions in. We'll try to get them in. We urge you to take advantage of commenting on the follow-on resources that will be associated with this meeting and all the meetings in the Maternal Health Series. This is our 4th meeting, but take advantage of those online, comment on the blog and such. The next meeting, a short advertisement, will be in May 20th, from 3 to 5 in this room. It'll be a workshop focusing on improving transportation and referral for maternal health. So that is what's to come in May. So I'll stop talking because the more interesting people are to my left. I will give them a very brief introduction. They have longer bios in the handouts that it's along with the participants list that you could pick up outside. But we'll go in order that they'll speak. Karima Tunau is OBGYN at Usmana Dan Podio Hospital, close, hopefully, in Nigeria. And so she'll be talking, as we said, about the cultural and financial barriers to family planning in this context. Next, we'll have Nabila Malick, who is the director of the Rahnuma Family Planning Association of Pakistan. So we will move eastward and hear about the experience in Pakistan. And then Grace Kodindo, who is assistant professor of population and family planning health at Columbia University, is from Chad, lots of work in the Chad and Sudan border. In fact, was just there, working on family planning, maternal health in the refugee camps. And so Grace will go third, and then batting cleanup, Saundra Krause, who's the reproductive health program director of the Women's Refugee Commission, will, after these 3 field-based perspectives, talk about it in kind of 1 or 2 steps up and be a great wrap-up, put it in the policy context and those challenges as well for us. So I'm going to get off the stage. Here are our guests. Thank you all for coming. I should say, because we are webcasting it, when it comes to the Q&A time, ask that you let us know if you have a question. We'll bring a microphone to you so you can let us know who you are and pose your questions so the people online can hear as well. So, Karima, can I turn the floor over to you? Thank you very much.
Good afternoon, ladies and gentlemen. My name is Karima Tunau. I'm an obstetrician gynecologist at the Usman Dan Fodio University Teaching Hospital in Sokoto, northern Nigeria. First, let me give you some background on Nigeria. We are the giant of Africa and have a population of about 150 million. I'm sure the vast majority of you have heard of Nigeria for not too good reasons, ranging from our political instability in past years to some few areas of unrest in a few regions. Much of this unrest is in the oil-producing Delta area, where we have some conflicts, and also in Plateau State, where there are some ongoing clashes. There are three major ethnic groups in Nigeria: the Hausa, the Yoruba, and the Igbo. However, over 400 languages are spoken nationwide. And we're also a religiously diverse nation, with about 50% of us being Muslim and the other 50% being Christian. But I believe only a few of you have heard of Sokoto State, where I come from. Sokoto is in northwestern Nigeria. It's one of the most peaceful places in Nigeria, where about 4 million hardworking citizens reside. Majority of the population, that's about 80%, live in the rural areas and are mostly Muslims. Nigeria has one of the highest maternal mortality rates in the world. Our figures are about 800 deaths per 100,000 live births. Our total fertility is also high, about 5 children per woman on average, and our nation's contraceptive prevalence rate is very low. Only about 10% of couples use family planning. These figures are even more troubling in Sokoto State, where the literacy level is very low and women keep on dying in childbirth. In my area, 1 out of every 18 women will die in childbirth. That means in every family, somebody's sister or mother or aunt or niece would die. It's unacceptable. That's why when I was choosing a medical specialty, I decided to become an OBGYN. The Usman Danfodio University Teaching Hospital, where I work, serves as a referral center for not only the populace in my state, but also for people from neighboring states, such as Kebbi and Zamfara states, and even neighboring countries like Niger Republic. The total population in these 3 states is about 10 million people, and the predominant ethnic groups are the Hausas and the Fulanis. Our center is a tertiary hospital, meaning we provide the most advanced level of services and receive transfers from lower level health facilities. My hospital takes care of all aspects of reproductive health, ranging from safe motherhood, issues related to fertility, prevention and management of genital tract malignancies like carcinoma of the cervix, child health, and a lot more. It will not be possible at this forum to discuss issues related to all these, but what I would like to do is to try and highlight 2 of our most pressing issues. These are maternal mortality and access and use of family planning. I'm in charge of family planning and fertility issues at our hospital. In our center, we have about 3,000 maternal deliveries every year, and our maternal mortality ratio in the state is about 850 deaths per 100,000 live births. However, in our hospital, which typically receives the most complicated pregnancy cases, our maternal mortality rate in the year 2005 was over 4 times the state average. We had a rate of 3,000 deaths per 100,000 live births. Why? Because we found out that the majority of these deaths, over 90% of them, were from emergency drop-in patients who often received no care during pregnancy, suffered from extreme poverty, and came to our hospital too late during their labor. The good news is that through a number of innovative interventions, we have dropped this figure by more than half over the past 4 years. How did we achieve this drastic reduction? One thing we did was to set up an emergency fund that would pay for the care of any woman who came to our center during pregnancy and labor. I should explain that, unlike in the US, most hospitals in Nigeria require payment upfront for facilities such as antibiotics and anesthesia before providing services, or they require a waiver process that could take many days for approval. Therefore, poor patients often experience long delays at the hospital waiting for care, or delay seeking care until they can secure funds. So, in our institution, our emergency fund enabled us to quickly and efficiently provide obstetric care immediately when someone arrived at our institution, thereby dramatically increasing survival rates. I also mentioned that I want to talk about contraceptive availability and use. And I had earlier on said our usage is quite low, but I did not mention the reasons. One major issue is that we face continuous frequent stockouts of supplies. In Nigeria, we get our family planning commodities from the Federal Ministry of Health at a highly subsidized rate. Unfortunately, there are times when many months have gone by and we have not received any contraceptives from them. For instance, for close to a year now, we have not had a supply of one type of contraceptive method, the implanon subdermal implant. It is the most requested contraceptive in our clinic because it's long-lasting, and once implanted, it will control fertility for 3 years without needing additional hospital visits. Presently, we have a list of over 100 women waiting for it to be made available. These women are at risk of unplanned pregnancies as they wait endlessly. This same example has happened with a number of different contraceptives. When contraception is not available, it discourages our clients from returning to our clinic and also creates a negative image within the community, as they do not bother coming to our hospital because the contraceptive agents are not available for them to access. Another challenge is the issue of cost. In Nigeria, an injection of a hormonal contraceptive, for instance, costs about $1.30. While this cost may seem small, it may not be affordable to a number of women in Nigeria. Apart from the direct cost, there are some hidden costs such as the cost of transport, as many of our clients have to travel from afar to come and access our services. How have we met these challenges? One thing we have done to solve the problems with stockouts was to establish a revolving fund and a committee to ensure a steady supply of commodities. This way, if we are running out of supplies and cannot get supplies from the Ministry of Health, we have an in-house fund that allows us to buy supplies directly from other retailers in our state. Unfortunately, this is much more expensive and requires many more resources. Another thing we have done is establish a full-fledged family planning clinic from scratch. This allowed us to provide services all days of the week from 8 a.m. to 4 p.m. Previously, family planning services had only been provided twice a week, and we found that only 14% of the women who delivered in our center had been using contraception. Our family planning clinic started in October 2007 with just $1,600, which we borrowed from the hospital management. We were assisted by the United Nations Population Fund in Sokoto, and they provided us with some office equipment. You would be pleasantly surprised to learn that since inception 2.5 years ago, we have already seen and counseled over 4,400 women about contraception and reproductive health. And guess what happened to our contraceptive use among the women delivering in our facility? It doubled to nearly 29% within this short period. We discovered that once our family planning services were regularly available, women kept on informing one another, and without banners and advertisements, we found ourselves managing troops of women in need of our services. Apparently, ignorance and lack of access to client-friendly services were some of the major contributory factors to our high unmet need for contraception. Majority of our clients, over 90% of them, are Muslim housewives, and in fact, about 35% of them do not even have formal education. The number of deliveries are high, with an average of 5 children per client. Interestingly, we now have a significant number of women who come together with their husbands as a couple. This was an unusual finding, as it is not the usual practice for Muslim wives to be seen with their husbands in family planning facilities. What this suggests is that there is improved level of acceptance of family planning services among our menfolk, as couples learn about the positive impact of family planning and the improvement it has on the health of the mother and the newborn, and it spaces children to the healthiest intervals. We find that acceptance of family planning increases. In conclusion, I'm hoping that as the United States decides upon its investments in global health and development, your government will take our experience in Nigeria into account and prioritize 3 areas. 1, emergency obstetric care services. 2, contraceptive security. And 3, female education. On emergency obstetric care, our success in reducing our maternal deaths shows that providing creative financing that pays for the immediate care of patients in childbirth makes an enormous difference. Why not ensure that every tertiary hospital can secure the funding to do the same? Second, related to contraceptive security, again, our hospital used creative financing to ensure a steady supply of commodities. But it is not enough. Perhaps it's high time contraceptive providers and other agencies involved in the provision and promotion of contraception you deal directly with remote centers like ours in order to reduce the bureaucracy involved in the past. This, I believe, would ensure continuous and constant availability of contraceptive agents. Third, is our belief that if we really want to see a difference and improvement in reproductive health in the predominantly Muslim northern Nigeria, one of the simplest and most important ways is to invest in female empowerment and education. An educated woman is likely to be better nourished, likely to marry later, likely to avail herself for care when she becomes pregnant. She's likely to be better to be able to take care of her family and would likely choose to space her births appropriately. An educated woman is an empowered woman. An investment in female education is definitely a long investment that would promote the existence of a healthy family whose size is determined by the choice of the woman and not by chance. Lastly, I would like to thank SEDFA for inviting us here once again. We are particularly grateful to the UN Foundation for making this trip possible and for the Woodrow Wilson Center for giving us the opportunity to tell you about our work. I hope in future you would sponsor more women like us whose interest it is to safeguard the healthy well-being of women. We fervently hope that this liaison will translate to the betterment of the lives of the majority of women worldwide. Thank you very much.
Hello and Assalamu alaikum. My name is Nabila Malick and I work for Rahnuma Family Planning Association of Pakistan, which is one of the 180 member association of International Planned Parenthood Federation, that's IPPF. Let me first tell you about my country. It's a beautiful place where 176 million warm-hearted people live, whose sense of humor is miraculously alive even when they are being showered with bombs everywhere. Many of you may think that the conflict in Pakistan is limited to the northwest of the country, but let me share my experience, and I work and live in what is considered to be a secure place in Lahore, and I have narrowly escaped 4 bomb blasts in the last few months, 2 very close to my office and 2 very close to my house. But war or no war, my line of duty requires that we are there for the ones who need reproductive health services, and we are. In fact, the conflict situation has made these services even more crucial. The marginalized people rely mainly on our free services, and the internally displaced people also expect us to be there. And frankly, we don't have a choice. Today, I want to talk to you about 3 pressing issues in Pakistan. One is maternal mortality and its link with women's low status. 2 is the access to services, especially in conflict setting. And 3, meeting the needs of the youth. As you're well aware that the studies show that maternal mortality rates have improved in Pakistan. However, it still remains unacceptably high, as every 20 minutes a woman dies during childbirth or pregnancy. And the unmet need of contraceptive is still very high. The national figure says 33% of population, but at some rural areas where we did research, it is as high as 59%. The high maternal mortality is directly linked with the status of women in Pakistan. The situation of women is a complex one. On one hand, we have women prime minister like Benazir Bhutto, but on the other hand, we have members of parliament who feel that burying unchaste women alive is not a crime, but a tradition that needs to be taken pride in. So why do mothers die? Mothers die because they there are no services for the poor. Because the women are victim of brutal customs like honor killing and swara vini. Swara vini are the customs in which girls, sometimes as young as 4 years old, are given away in marriages to the enemy's family to settle disputes. Because women are not valued, because women are not educated, because they don't have freedom of mobility, because they don't have decision-making powers, because they have no control over their bodies. Their lives are valued so low in the villages that if you ask men, they'll be willing to spend money to save their livestock, but not their wives. And their argument is that if you have the source of income, you can always have another wife. But if you lose a cow, that's a problem. It is against this background that women continue with their role of procreation. Pakistan is the world's 6th most populous country and will slip further down sooner than predicted if the contraceptive security is not ensured to the 52 million people who want to use contraceptive and can't access it. Compounding these challenges is our conflict situation, which brings me to my second point. One of the outcomes of the conflict is the internally displaced people coming from the northwest of the country, escaping the disastrous effects of the war. Their situation does not stop the process of childbirth. For some reason, the number of cases increases either due to violence or sheer frustration coupled with lack of contraceptive availability. These people need services and counseling on emergency basis. My organization, Rahnuma Family Planning Association of Pakistan, needs to be prepared for such situations ahead of time. When people in Swat were being displaced due to the war conditions, we immediately moved into action and mobilized funding for the emergency response, but by the time we completed the process, it was too late for a large number of people. Our situation requires that we should have the resources to immediately move in when the need arises. If we are not ready to deal with emergency situation arising from the internally displaced people due to the conflict, the maternal mortality statistics will further regress. My third point is, Pakistan at this very moment is at a very interesting point in history. Around 60% of its entire population is below the age of 29. This opportunity needs to be utilized to change the country's future. These young people are ready for change. This is the time to give them information and services to develop healthy and responsible attitudes towards sexual reproductive health and rights. If the youth remains ignorant of reproductive health information and remains without access to any kind of reproductive health related services, we'll waste this biggest opportunity provided by the fertility transition. The problems are enormous, but not unsurmountable. Let me tell you about the work of a single organization that I work for. We pioneered the family planning movement in 1953 in Pakistan. We were stoned, we were called prostitutes, but that's the thing of the past. Today, my organization is the largest reproductive service provider in the NGO sector, with a network of 11 hospitals, 170 clinics, 11 mobile units, and 2,275 private practitioners, coupled with the army of volunteers, but we still cannot reach out to all the people who want family planning. At one point, we used to provide family planning services to almost 10% of our population, but then we were defunded due to US restrictions, including the gag rule, and that brought the percentage down. Rahnuma Family Planning Association of Pakistan also runs an exclusive program for youth. It has youth resource centers, a place where the young can come together, get information, plan future actions. With the little support and training that we were able to provide them, these volunteers have started impressive campaigns for their sexual and reproductive rights in Pakistan. We are also trying to make all our service delivery points youth-friendly to support them. We also have various programs for empowerment of women and a couple of centers where we provide skill development trainings to women for their economic independence. In order to increase their access, we have Men Engaged program because leaving men out does not work. Sorry, that's a problem with papers. In a place like Pakistan, the only way to control HIV and AIDS epidemic is to provide the services through reproductive health outlets, because the stigma attached to the disease makes it difficult for people to access the centers exclusively designed for HIV and AIDS. The HIV/AIDS program has to be integrated with the reproductive health program. Only then will it be effective. We have back home special programs that we are running to increase the access of female sex workers and other sexual minorities to control the spread of the disease. There are a number of issues we are hard to deal with, but we are doing it and we know how to do it. And here is what you can do to help us fix things. 1. Ensure that the support for family planning and reproductive health uses a sustained and long-term approach rather than being subject to political winds. For example, there is an immediate need to start redirecting funds to groups who got defunded due to the gag rule, so they can again become more effective. Although gag rule was removed early in 2009, but the funding has not yet been restored to major players in the sexual reproductive health like IPPF. And in Pakistan, it will make all the sense for the US government to work for the largest organization in the reproductive health services, but we are still waiting for our partnership to be revived so we can regain our strength back. I will strongly suggest that the gag rule should be permanently removed so we can continue with our work without the fear of setbacks in future. Secondly, invest more in adolescent programs. For those who believe Pakistan is too chaotic and nothing will work there, we have many successful examples. So trust us. We are in the front line. We know what is needed. And support us in giving our youth a fair chance. Health system strengthening has to come through private sector, through NGOs like Rahnuma Family Planning Association of Pakistan, who enjoy the trust of the communities. And finally, help us integrate critical interventions like gender-based violence in family planning and reproductive health programs. Women are important, but so are men when it comes to reproductive health initiatives. 90% of the calls we receive on our reproductive health helpline are either by men who are seeking information about their reproductive health or by women who are seeking information for men on their reproductive health information. So don't leave them out. That's all I had to say, and in the end, I want to take this opportunity to thank UN Foundation for making it possible for me to come to Washington and talk to you directly. I would like to specially thank my friends at SETPA for their support and the Woodrow Wilson Center for this opportunity. I'm grateful for this opportunity to meet all of you, network with people whose support can help us bring positive change we are working for. Trust me, to a large majority of women in Pakistan, this change means defeating death. Thank you.
Good afternoon. My name is Grace Kodindo. I am from Chad. For 30 years, 1977 till 2007, I work as general practitioner first, then OB/GYN, then advocate in Chad. I advocate principally for maternal mortality reduction. I have made a film with BBC named Dead Mom Don't Cry about this issue in Chad. But for the last 3 years now, I am working with the RAISE initiative. RAISE is an organization working with other humanitarian relief organizations for improving reproductive health services for displaced people, especially the refugees and the internally displaced people in Africa, Latin America, and some part of Asia. So I'm going to talk about Chad. Okay. A problem?
Press F5.
Closing and opening it may have
Okay, yeah.
set it off a minute. Let's at least get you full screen. And then maybe we'll stop flashing as well. Oh, now I've done it. Okay.
Oh.
No.
Okay. As you can see, Chad is a landlocked country sharing his border with 6 more African countries. You can see that.
No.
Technical help? Yes.
We've learned that the hard way. When in doubt, when giving a presentation, don't close the computer tab. It's a big, it's a challenge. But thank you, Paul.
Sure, no problem. Stick out.
I almost jumped out of my seat when you did it. I was like, oh no, please, please, please.
Might have to. Might have to swap out this computer, Jeff.
Okay.
Don't know why it's doing that.
Maybe I'll need to give that presentation off my USB port.
To swap it out.
Okay.
It's,
Do you have a PowerPoint?
Do you have a copy?
Do you have a PowerPoint?
Yeah, I have. I just want to show that.
If Paul's going to switch the computer, if you want to talk from those, and then we'll try to get this on the new computer. computer as fast as possible. I'm so sorry.
Okay.
Yeah, he needs to switch. So, but Grace, if you want to do that, then they can play over here and fix that.
Okay.
No,
Anyway, you have already seen the map.
We all have good imaginations here. We can see.
Exactly. The map was just to show you two things. The country is landlocked. It's a very large country, and this already constitutes a real barrier to access to family planning services and other maternal health services. This is the 2 points that I have tried to make. The second slide was to show you how Chad was a real example of a fragile state. Chad became independent in 1960. And from 1960 till today, we have known conflict, civil war, instability. Even last weekend, they had a very hard fight between government army and the rebel in the border of Darfur and Chad. Such a way that we had no real peace for the last 50 years. And like in many countries where the conflicts are almost perpetual, reproductive health services are not the priority. The priority in these countries is first, of course, the war, to make war. So reproductive services are not really considered as a priority in Chad. And since 2003, not only we had our own conflict, but we had also the conflict in Darfur. We gave us 280,000 refugees from Darfur. We had 170,000 displaced people in Chad, and we have 55,000 refugees from Central African Republic. So that makes a lot of burden on the weak capacity to address the needs of family planning for just one country. I have just also wanted to show you the typical indicator for all fragile states. So in Chad, we have not a very big population, not like in Nigeria. We have only 10,325,000 population, but 47% of them are aged less than 15 years. So can you imagine when these people will come into reproductive age, the need for family planning and other maternal services that will be added to the already existing huge unmet need. Almost 75% of the population in Chad live in rural area. And this is another problem, because those are the people who have the geographical access to good quality services. They are the one, this is where most of women are dying. This is where women have difficulty accessing all maternal health services, including family planning, because of the lack of trained staff people able to provide the services in those remote and rural areas. Life expectancy in Chad for men is 46, and the women 47. And like typically where you will have under 5 mortality rate is 209 for 1,000. So where you have high child mortality, where you have low literacy rate for women in Chad is 20.8%. It means that almost 80% of women are illiterate. So when you have high child mortality, you have low fertility, you will have, of course, high desired fertility. Because children are dying so many, they want to have as much as possible to replace the one who are dying. So the fertility rate, total fertility rate in Chad is 6.3%. Maternal mortality, I think that even Pakistan and Nigeria did nothing about that. We have 1,099 per 100,000 live birth. And skilled birth attendance, 14%. And contraceptive prevalence for any method, 2.8%. So this is and I would have liked you to see the slide, because I would have wanted to see the link between each one of reproductive health. I would like to see that how infantile mortality can have impact on high fertility, on high maternal mortality, and when low prevalence of family planning can also have impact on high under 5 mortality. Because when children are not well spaced, the infantile mortality tend to increase. So each one of these different components of reproductive health do impact each others. This is why I think more in terms of comprehensive reproductive health services than for group working on family planning, another one on maternal mortality, another one on children problems. They should be integrated because they all impact each others, especially in developing country. I wanted also to come now to the cultural barrier in Chad. Of course, Chad, like many other developing countries, is a pro-natalist culture. This is why I remember in the beginning, the government was so afraid of using family planning word, because for them it's too linked to family limitation. So they prefer to use family well-being instead of family planning. And the contraception was promoted in the beginning only for spacing, for birth spacing. Then that was all, because they were afraid to go against the cultural belief. And also because birth spacing actually is also cultural in Africa. In our traditions, the right space was about 3 to 4 years, even 5 years. This is why in the old time, when a woman delivers, she's sent back to her family to stay there for 3 to 4 years before coming back to her husband. And that was a way of family planning. And I used to tell some of my colleagues, African, that at least if a contraception, you can keep your wife with you instead of sending her to her family for 3 to 4 years. So you should be happy and grateful. I'm teasing them for that. And another cultural factor also that plays on that is the status of women. Women used to be valued by the number of their children. You know, the more you have, especially if you have, boys, the more you are valued in the family. And I would like to come back later on when we talk about what we expect from you in terms of this point. I will try to explain a little bit more. Today is no longer that. That was in the past. But today they have seen how educated women fare better and can, play a role in the society. So this thought is no longer really so important. I wanted also to talk about as my colleague have said before, cultural factor that really impact is the high level of illiteracy. Like I have to say about the Chad, almost 80% of women are illiterate, and this should not put too much emphasis on that, because even the illiterated, when they can have access to services, good quality services, and when they have good explanation, good information, this is not really a problem. So the problem now is mostly the lack of information, good accurate information, and also, of course, the difficulty accessing the services. And another cultural factor is that even some health provider sometimes can be a real barrier to family planning. 1 month ago, I was in a refugee camp in Bahai, border Chad, Darfur, and we had a problem with a woman, unmarried woman, who went to a health center to ask for family planning, and the health provider refused to provide her. He was asking her, are you married? Where is your husband? Did your husband give you authorization? So sometimes even the health provider can also be a real barrier. This is why they need to be trained and they need to know about the new laws and what's going around. Chad is a French-speaking country. French-speaking country in Africa compared to English and Anglophone one, there is a big difference in this field, because we, during the colony, we have had the old French law dating from 1920. And that law prohibits sale or promotion of family planning. Even French people got rid of the law. But we Africans, we stick to it. until the beginning of the 21st century. Could you believe that? We start to have law changing this law only in Chad. It was in 2002. In Mali, Burkina Faso, it was 2003. So that has really, this is why family planning program in French-speaking country started later. In Chad, it started in the late 80s. But we start to talk even about family planning methods. And that has really produced a delay between Anglophone countries and us.
Grace, we have the slides now.
Oh. Okay.
You're very graceful in stepping in, so to speak.
This law has been a barrier for many years. Now it has changed since 2002, even if we need to do more advocacy because it's not really completely known by everybody. I just gave the example of that health provider who is still refusing to provide family planning to unmarried women. Our problem in Chad is mostly the availability also of the services. In the public sector, if it was not from UNFPA, there would be no contraceptive in the public sector in Chad. UNFPA is the only donor. And the contraceptive in the public sector provided by UNFPA in some places are given for free. So anyone can have access to that. But in rural area or in remote area, this is still lacking. Because as my colleagues have said before, not only there is a lack of information and services, but there is also the problem of transportation and train staff to be posted and provide services in this remote area. And we will see later on some part of the population also are not really benefiting from the services of family planning. And thanks God we have the IPPF, Chad Association. I am one of the founder member. And this association is with the UNFPA the only provider of good quality contraceptives that are sometimes, affordable for people. And the private pharmacy is just too expensive. There is no way for common people to really access this product in the private pharmacy. What has worked in Chad? I think advocacy. Advocacy is something that is very important. Advocacy first toward the country government to change policy, to change law that would facilitate the provision of contraceptive. This is very important. And also advocacy toward donor government like USAID, like other government, because if this country can show that, can consider that woman's life or woman's health is important, they can influence the government of the country where the woman's status or woman's value is not so high. Because when they know about it, when they consider that woman's life is very important, and they make sure when they are dealing with this government that this is their priority, they will be forced to put that also in their agenda, which is not always the fact even now in many places. And also the services. When accurate information and quality services are available, people just do use it. 1 month ago, I was in that refugee camp training the midwife from Darfur, and we were talking about contraceptive use. These women are from Zagawa tribe, Muslim. The Zagawa tribe are one of the most pro-natalist tribe in these areas. And I used to be told that they don't like contraception, especially long-term contraception. But when I sat down with them, and when I started to talk with them, I found out that I had actually nothing to convince them. They were convincing me about the benefit of family planning. Some of them were telling me that they feel like they are some hens with many chicks walking behind them. That was their expression. Because they are overburdened, in the way they are dealing in their everyday life. They are refugees. They have a lot of children to look after. And they need. They told me that it's only ignorance. It's only lack of information. If someone can sit down with them and explain to them exactly how these drugs work, what are the side effects, How can they access it? There is really no problem. But so the first priority is to make these services available, and you will see that a lot of the misbelief about these people don't need that, sometimes it's not really not the problem. And the availability and accessibility. In Chad, we have seen that in the 2 districts, they have started in 2007 to use mobile clinic to bring to people where they live the services. And in these 2 districts where the family planning consumption was 0%, it has just increased. People were not using it because they did not have the services. That was as simple as that. So mobile clinic in places like Chad, where accessibility, geographic accessibility is a problem, can really be very, very helpful. Our problem in Chad is what? We depend only in one donor, UNFPA. In 2003-2005, during the years when UNFPA was having some difficulties, for 2 years in my hospital, we did not have no contraceptive. For 2 years. So, of course, now we need to have more donors, more funding, and including also this group that have been until now neglected: the rural people, the adolescent, the refugee and displaced people. And people used to think that refugees and displaced people only need to have food, shelter, sanitation, and that they are dying too many, they don't want contraception. This is not true. If you go to them, you see them, they have the same needs like all other human beings. And they have the same right to this service like anyone else. They have the same problem, the same needs. So we should really think about programs that respond to needs. We should do research, go there, do research, and produce services that are really respond to the needs of people. Not just making some, presumption, assumption, that and then not providing services. So it is very important to include this part of the population that are most of the time neglected. I have a chance to work with stable population while I was working in Chad. Now I'm working more with displaced people. I went in 2008 to train midwife from Burma, and one day I have a woman coming to me. She had 15 children. She came for her 15 children. She's living in the jungle, but she came for care. She was completely exhausted because she's farming. She famished, and I diagnosed some heart problem also in that woman. She need evidently some, for me it was tubal ligation. But the problem, she had no money to pay for the tubal ligation in the Thai hospital in Mesot. She had no money to pay for implant or even IUD that would last at least 6-7 years. And that was a typical case of need that you can find among these displaced refugees when you go to them. So the needs exist, and they want us to help them. And it is the right. So we have to really respond to their needs like everyone else. And for this, we need, of course, more funding. We need donors, we need government, and we need focus group that program that really can reach these people with good quality services that are not being imposed on them. You have to do it in a very respectful way. You have to respect the right. We just have to only provide services and let them decide on which type of contraception they want. And you can see that then we will be more able to really respond to their needs. And I have just talked about that also. There are many misconceptions. This is really, people are also overemphasizing the cultural factor as a cause that people have this kind of culture factor that prevent them from using family service. In Chad, just before I left, I was having even Muslim husband coming to me asking for contraception for their wife. That was not there 10 years ago. But culture changed, cultural factor changed. And this is very important for us to know that. It changed. And even the fact that men are against contraception, this also is sometimes some misconception. Of course, men, like everywhere else, may feel threatened. I'm sure that even men here in the state, maybe a few years ago, they were feeling threatened by the contraception, I'm sure. But the change in life, the change in the reality of life, produce also change in the attitudes. And we should not really overemphasize that. The family planning benefits are known by everybody now. People only need to have very good information, very good services that are affordable, such services, and you will see that we will really help to meet much better their needs. Thank you very much for your attention.
Very nice of Grace to handle all that for me. That is doing without the computer. Let's see. Yeah, here it is. It's not supposed to. Okay, good afternoon, everyone. Thank you for being here. I'd like to also thank the panel organizers, the Woodrow Wilson Center and SEDPA, for the opportunity to be here with these esteemed panelists and to be able to speak to you about improving access to reproductive health in fragile states. My talk is about making select recommendations with regard to that. So why is it important in fragile states? Well, conflict-affected countries have some of the worst reproductive health indicators. The recent Lancet report on maternal mortality shows that conflict-affected countries comprise 4 of the 5 countries with the highest maternal mortality in 2008: Afghanistan, Central African Republic, Chad, and Sierra Leone. I'm just going to show you a few slides to kind of give the context. This is the Rift Valley in Kenya following the post-election crisis there in 2007. Just to show you what can happen in these crises. Facilities are burned right to the ground, for example. This is in Aceh province, which is also conflict affected, but then again affected by the tsunami. This is a situation of forced displacement in DRC. Just to give you a glimpse at what some of the reproductive health risks are in emergency settings. As Grace was saying, people's reproductive health needs don't, go away, and when they're facing these catastrophic events, in fact, they can become worse. In any crisis situation, there'll be women who are pregnant. About 6 to 14% of women will be pregnant, and among them, 15% will experience some unpredictable complication of the pregnancy and require emergency obstetric care. But there they are, delivering along the roadside or in a makeshift shelter, or in the case of Kenya, on the buses as they were fleeing the area and the conflict. They may have left, forgotten their birth control method or condoms. Families, communities, the whole civil society as people know it are broken down, and without access to information and services, adolescents are at risk. And then there's the problem of sexual violence. Sexual exploitation and abuse occur in conflict settings and natural disaster settings as people are trying to get their basic and survival needs. So without ready access to that, they might be in a position where they have to exchange sex, for example, for food rations. Rape occurs more in the disruption of civil society and as a tactic of war. All of the sexual violence leaves women at risk of sexually transmitted infections, including HIV, unwanted pregnancies, and unsafe abortions. So there's this need kind of there, and then the health infrastructure is highly affected by this. Whatever was there before is no longer necessarily available. It's likely been weakened or destroyed. The health worker shortage is compounded as health workers themselves are grappling with the effect of the crisis on themselves personally, whatever that means for them, and so they're not necessarily able to go to work if there is a facility and if there are supplies there, because logistics systems sometimes ground to a halt and sometimes just barely falter along. So, sorry about this slide. That's supposed to be the average long-term refugee situation lasts 17 years. So I talked to you about the immediate onset of the crisis picture, but then there's the long-term situation too, where the political context is such that the conflict's tractable. And there are these long-term settings. And then there are all kinds of settings and circumstances in between a long-term stable sort of refugee camp setting in the transition between an acute emergency. So just starting with a little bit of what does the policy environment look like, the International Conference on Population and Development recognized refugees and internally displaced needs explicitly in the Program of Action and their right to reproductive health services back in 1994. And since that time, a number of guidelines have been established. Among the first of the interagencies guidelines on reproductive health in refugee settings. I'm just going to hold these up because all three of these guidelines are either currently under revision, recently revised, or recently developed. This is the Interagency Field Manual on Reproductive Health, and the revision is coming out, being launched first next month. Then the Global Health Cluster just developed guidelines. WHO leads the Global Health Cluster for humanitarian settings. There's a health cluster guide. And then there are the sphere minimum standards and disaster response. And I guess what I want to say about all these guidelines is that they are consistent in their recommendations for reproductive health. And specifically, they recommend a minimum initial service package of reproductive health services at the onset of an emergency. These are a set of priority, very limited activities to be implemented right from the beginning of any emergency. They include ensuring that there's some form of coordination for reproductive health within the broader health sector. They include protecting measures to protect women against sexual violence, and then measures to ensure that women who have suffered sexual violence have access to care, such as emergency contraception, PEP to prevent HIV. Limited measures to reduce the transmission of HIV, just ensuring the blood is screened for transfusion, condoms are available, and people are practicing universal precautions in health centers. Limited actions, again, for preventing maternal and newborn morbidity and mortality. That is, ensuring that skilled health care workers are available to provide basic and comprehensive emergency obstetric care. And also clean delivery kits for women and girls on the run who are pregnant and due to deliver, visibly pregnant, and then planning for comprehensive reproductive health. There are three important notations to this MISP, and one is that contraception should be available from the onset of an emergency to meet any demand. That means condoms, pills, injectables, IUDs, emergency contraception should be available to meet any demand at the onset of emergency, as should antiretrovirals for anyone who is already taking them, for HIV/AIDS, and including for preventing maternal-child transmission, and also care for sexually transmitted infections. So anyone who presents should get that care. Still very, very limited approach to reproductive health in the MISP. There is a laminated sheet outside that kind of outlines the difference between the MISP and more comprehensive reproductive health services, which should be established as soon as the situation starts to stabilize. So in other words, sustain the MISP activities, but build upon those MISP activities to ensure comprehensive maternal and newborn health, family planning, care for sexually transmitted infections, broader gender-based violence care, safe abortion care, and care for adolescents. So have these guidelines been followed? Does the global policy support these findings? Well, these recommendations and these guidelines? Not really. The Reproductive Health Access Information Services and Emergencies, RAISE initiative, which is led by Columbia University's Mailman School of Public Health and Marie Stopes International, of which the Women's Refugee Commission and JSI are part, conducted this global policy analysis, looking at the policies of governments, EU institutions, UN agencies, and foundations. Let's see if I can get this pointer to work, maybe. No, that's not it. There's a pointer here. Okay, that's all right. Well, anyway, the graph, the pie chart on your left shows the policies. The one on the right is our guidelines. But basically, they show about 15% of the policies cover comprehensive reproductive health. Another 12% deal with reproductive health and rights or women's health. But then 19% deal with the important issue of HIV/AIDS, and 19% deal with GBV. On the other hand, emergency obstetric care was only mentioned in one policy, and that's included in the comprehensive reproductive health analysis there. And family planning only 1% of policies included family planning. Similarly, this policy study complemented a race-initiated donor study, which was conducted in 18 conflict-affected countries from 2003 to 2006. And it found the annual average of 2.4% of total ODA, overseas development assistance, was allocated to reproductive health, and only 1.7% of the 2.4% on average was dispersed to support family planning. So, so quite a drop there. And I guess what both the policy and funding shows is that, well, there was important allocations to HIV and gender-based violence. The approach is fragmented and doesn't complement the holistic, comprehensive approach of ICPD that's important for us to achieve the Millennium Development Goals. So what should be done? Well, policies and funding should support the existing guidelines and standards. It should support the MISP, should support comprehensive reproductive health as soon as the situation starts to stabilize. It's also important to ensure that the reproductive needs of refugees and IDPs are fully integrated into any broader health proposals, such as the Global Health Initiative. That is, in every country, the needs of the refugees and the IDPs in that country should be considered. And there's lots of reasons for that. One, the humanitarian funding tends to be very short-term, and even if it's there at the onset of crisis, it's not necessarily going to be there when the crisis is no longer garnering attention, and then there's no funding. But by building it in, by giving the capacity to the Ministry of Health, the development agencies already on the ground, and local actors, by supporting them in RFAs and so forth, then the capacity is sustained in the country. It's also important to support the leadership role of national and local authorities and build the capacity of local NGOs, including beneficiaries. It's not only important because it's really a fundamental right of theirs to be part of the solutions to the problems they're experiencing in the country, but it's also important in filling this transition from the relief phase to long-term development, or even to development at all. There's a tremendous gap in the transition. And so supporting these groups are more likely to prevent that gap. So one of the specific recommendations is supporting collaborative partnerships. The international community has long benefited, the global international community working in reproductive health, the humanitarian community, has really benefited from collaborative partnerships, from working together on advocacy, on developing standardized curriculum, trainings, and within that, groups like the Reproductive Health Response and Conflict Consortium have supported local NGO partnerships, and JSI has taken the lead for the consortium on that, and currently is supporting a project called Astarte. There's information about it in the back, but also it's a collaborative partnerships where local NGOs can work together with shared curriculum and shared service delivery approaches. And there's, I did say that, some information in the back of the room. And then they've also published, JSI's been working on this for a long time and has published reports on the success of these projects. One of the reports is Small Grants, Large Gains, also in the back of the room. It's also important to include reproductive health and emergency preparedness and contingency planning. We already heard a little bit about that from the panelists, that by having governments, ministries of health, development agencies, and local NGOs trained in advance in the MISP and pre-positioning supplies and materials, those groups are much better able to respond in any new crisis, and certainly in any sudden onset type of emergency, because they're already in the country. So by embarking on emergency preparedness, training, stockpiling of resources, it capacitates the local actors. And then there's an important issue of urban displacement. The global urbanization, 50% of the world's population is now living in urban contexts, and this is mimicked also in refugee settings, with 50% of refugees now in more of an urban context. And And I think, again, the Ministry of Health, the development organizations, and local NGOs are best positioned to respond to the needs of urban populations. And fourthly, supporting community-based approaches to service delivery. Grace mentioned this, mobile outreach, including with long-term family planning methods and community-based distribution of family planning. Now, that's long been popular in the development context. A lot of research and implementation has been done, but not as much in the humanitarian context. So much more is needed. Some groups, like the Global Health Access Program, have actually taken on community-based reproductive health care. There's a terrific project in Burma for IDPs where they just can't have health facilities. That's called the Mobile Obstetric Maternal Health Project, and a cadre of community health workers provide all the obstetric care except for C-sections. And the Women's Commission is working now to integrate into that project community-based care for women who have survived rape so they can get access to care that they otherwise wouldn't have because health facilities are not really possible on that eastern border in the IDP area of Burma. So in summary then, policies and funding should support the implementation of existing standards on the MISP in emergency preparedness and response, comprehensive reproductive health as the situation stabilizes, and throughout protracted crisis and recovery. It should include refugees and IDPs in any health or reproductive health initiative and country. They tend to be forgotten, even if whatever initiative it is, they're sort of forgotten, and they should be included. And support capacity building of local NGOs through network approaches and collaborative partnerships. And in general, community-based approaches to service delivery where health facilities is just not feasible or possible. Thank you.
Well, thank you all very much, and Grace, particularly thank you for the grace with which you handled that AV challenge there. But you have all given us a very challenging landscape, yet some very specific things that work, some very specific misconceptions to not fall in the trap of going down some blind alleyways that are counterproductive. It's set in very different geographic contexts. So thank you all very much for that. It gives us a real rich basis from which to have a conversation, which we will turn to now. As I mentioned, because we are broadcasting it on the web as a webcast, we ask that you use the microphone. Let us know who you are and pose your question. Feel free to pose it to the panel or to a specific speaker. And so who would like to start us up in that endeavor? Dan, if we could come down here, down front.
Good afternoon, and thank you. My name is Leah Frage, and I'm the Gender Advisor for Extending Service Delivery Project. We have a project working with IDPs and refugees in Burundi. And one of the challenges that we're facing is that the government really doesn't want to even admit that they have IDPs. So they're sort of lost. How do you deal with a situation like that?
No, I mean, I guess I'm not totally surprised by that, and it's a really good point to bring up. I think it's the same situation as with the IDPs in Burma that I was referencing, and why, I think going somewhat back to the population with community-based approaches, and I talked about the mode of service delivery, but also of creating the demand, informing and educating communities, and creating the demand for those community-based approaches is possible. But I don't think that's entirely unusual, and then it does become very difficult to engage them to participate in providing the care that they're supposed to give. I mean, that's lots of times what creates the IDP situation is a hostility towards that population to begin with. So, no clear, no answer for actually fixing that piece of it, but maybe just some ideas for how to reach them with the services is probably the most important, but it is true. There's this separation between the government and the population. They don't have access to the services, and I think why we have to get really creative is support local community-based efforts, and not, just think that we can do the usual, what we all want, the golden Cadillac of establishing really great health facilities fully staffed with whatever is just not realistic in a lot of these settings.
Yeah, there is a new tool now. African Union last year, they have drafted something to fill the gap, because compared to the refugees, the IDP do not have any, legal document. But African Union has adopted last year a document for that. So that should be really normally, and I think Burundi is one member of the African Union. So I don't know if that should really help, that new document.
Okay, terrific.
I can send you the link if you leave me your,
yeah.
Okay.
Perhaps we can get it, and we'll include it in the web summary from this meeting so everyone can come to the site and get it. We got a couple questions from our web viewers, I think particularly perhaps posed to Nabila, but the rest of you chime in as well. And they ask, can you address the particular issues surrounding unsafe abortion for women internally displaced by conflict in countries where the laws regarding abortion are restrictive? And how much is that challenge contribute to particular facilities or some sense of high maternal mortality rate? And is there providing post-abortion care for patients who've undergone unsafe abortions? Nabila, would you like to kick us off with that?
To give a situation in Pakistan, 13% of the entire maternal mortality is contributed through unsafe abortion in Pakistan. So that's a high number. We are aware of it. There are efforts underway, and one of them, which is very encouraging, is the PAPAC. It's a post-abortion care of Pakistan. It's a coalition of all the NGOs. They have come together to have a package of comprehensive services, at least for the post-abortion care in Pakistan. But at this point, I would also like to say that in Pakistan, there is enough space in the law, and the services can be provided, and the need is to educate and to train service providers who are unaware of this space that is there in the law, in which the services can be provided to those who are seeking it, and they don't need to go to backstreet abortionists, which is also a reality and which everybody's aware of. But that is a very sensitive issue, and I'm very happy to see a lot of organization coming together to find solution towards it. So hopefully soon we will have definite answers for that, but right now we're just struggling.
Okay. I don't know if anybody else has experiences they want to share on that, or we can turn to other questions. Okay. Gentleman over here.
I'm Michael Bodakowski from the World Faiths Development Dialogue. Can you talk some about the role of faith-based organizations in family planning?
Gives you a lot of latitude, but...
In Pakistan, it's a country dominated 96% by Muslim population. We have, ever since our establishment in 1953, for acceptance of family planning, we took support from the religious scholars. And even now, since religious scholars have great influence over the communities, they are one of our partners, and we work with them. In fact, in the most recent incident, the youth campaigns that I was talking about, in one of the youth campaigns, the youth volunteers of Ranuma Family Planning Association, they got our religious scholars to actually go on the national television on air saying that comprehensive sexuality education in schools should be permitted because it's not forbidden in Islam. So we have sort of a very positive relationship, and they are helping us on these humanitarian issues in the development areas.
I think we have the same situation in Chad, where the government works very closely with. In Chad, also Muslim count for 60% of the population, but we work very closely with the religion leader, community leaders, and the parliament member. So they work very well together, also trying to improve this.
Yes, in Nigeria, the situation is also similar to what has been said. And the faith-based organizations can be both the Catholics, for instance, and also the Islamic community. And there are both proponents and opponents. But what we are beginning to see now is a change in attitude, such that gradually the proponents are becoming much more than the opponents. And there's a general level of most of the myths and misconceptions were due to ignorance, so people are getting more and more enlightened. So the acceptance, especially in the male folk, is actually increasing.
Okay, right back up there.
I apologize if I'm repeating a question that was asked earlier. I was out of the room at the beginning of the question period. I'm Helen Rafael, Resources for the Future, and I was wondering about the background of you women from Nigeria, Chad, and Pakistan, because your countries have, high illiteracy rates and are relatively poor, and a great deal of people from the countryside, and I was wondering how you three became so well educated and with the orientation towards medicine and obstetrics gynecology, and also about how rapidly people in your country are getting educated to be able to perform in the same way that you three are now performing, since again they are developing countries.
Let me start with myself. My dad, bless his soul, he just died 2 years ago. He was born as far back as 1924. And he had actually worked with, I don't know if some of you have heard of Ahmadu Bello, once the Sardauna of Sokoto, a very prominent figure. So he went to school. And naturally, everybody in my family went to school. It's not an option. Like, you have to, and all of us did. And we'll have 4 doctors, we'll have 2 engineers, we'll have architects, we'll have everything. So it's like, for us, for our family, it's not optional for you not to go to school. It's like, it's just natural. And so all of us have just inherited that, and all our children are also doing that. So there are many families like that, even in up north where I come from. And even as it is, even those families that didn't have that kind of solid background, like I was fortunate enough to have, those that are coming up are also realizing that we cannot do without education. So there's a great move now, even in the younger people that are coming up, to actually get educated. And of course, education is empowerment.
Well, Pakistan, the literacy rate is low. Female literacy rate is 36%. But it's a country of contradiction. You have women who are educated, but then you have the majority who is not. Fortunately, my parents were also educated, and they encouraged education, but to a certain level. So as soon as I was finished with my master's degree in Pakistan, that to them and to everybody in my family was enough. And if I wanted to go abroad to utilize the scholarship that I had won, then I had to get married. So it's fighting every inch of the way. And even today, it continues. So it comes with a price. And we are hoping that this work that we do will make it easier for our coming generations.
Thank you for that question, because it always helped me to see how grateful I am to my parents. My mother was illiterate. With all her sisters, they were all illiterate. But she fought for me to go to school. That was something very unusual. But my father was the one who has really helped me. He used to tell me, I expect you, the same that I expect from your brother. First, a profession. He said, you see, when you will have a good profession, men will be in line to wait for you to marry you. So that will even help you get a better husband than if you are not educated at all. So both of my family have really, because after I finished my high school, my aunt wanted me to get married. He said, well, she has gone on to high school. This is enough. Why should she go further than that? But my parents did not even want to hear about it. So I was lucky. I got a scholarship from Canadian, International Agency Development. They have allowed me to go to Montreal to do my medical school. So I was trained in Montreal, and after I finished in Montreal, I just went back to Chad. So thanks to my family, my parents, not my family, but my parents, because my aunt wanted me to get married.
Okay. I'd like to ask, you've all addressed this in some ways, but perhaps if there were some tricks or examples that you can show and kind of breaking through this notion that all of you spoke about in the sense of the perception or the misperception in conflict or crisis or humanitarian crisis that the reproductive health and family planning services they're important, but they're kind of second tier. They're lower priority. It's long term. We have to worry about the absolute immediate survival today perspective of that, and missing the notion that it's not long term. It's immediate, and it's part of fashioning a survival strategy and taking oneself out of that. When you're engaging with humanitarian organizations or other parts of the UN that isn't UNFPA that gets it, but has a long list of challenging aspects, but don't typically include these issues. What are the ways that you try to break through that conception of this is long term, and yes, it's important, but second, it can't be at the top of the list, and so it has to wait. Are there either tricks or cases that you use to make your points that try to break through that notion where it's not necessarily hostility, but a kind of mixture of competing priorities and ignorance about how critical some of these things are from day one?
Want to start?
Well, actually, I think that things are changing, and the international community now really does get this, but it's a matter of getting it out there. It's always been the women themselves, the displaced populations themselves, sadly, who've just had to demand the services before the international NGOs would get it, and they would in every crisis, every kind of crisis. They needed and wanted family planning, and they would pushed until people heard it, but that was all so much later, and those are the vocal women and whatever. But now it really is part of policy, and now the time is really to make sure that the funding goes to support the implementation at the field level. It's all here. We have all the guidance on the policy. Everyone's in agreement. And now we just need to do it. That means getting the funding and the supplies and the logistics, which are a big bottleneck, supportive for contraceptive commodities, making them available.
In Pakistan, what I can say is it's hard to make the connection, especially because it's considered to be a women's issue only. And since women are invisible, you don't see them, so you don't face that. The issue is not staring you in the face when you go visit these people. The initiative, the good thing, the encouraging thing is the partnership. The partnership between NGOs, the partnership between public and private sector. I think that is now finally bringing the holistic picture in front of the governments and the donor agencies. And it's sort of slightly easier now to make the connection with the reproductive health as well.
Yeah, I think as Sandy has said earlier, I mean, the first champion were the women refugees themselves. But now in many of these countries who happen also to be fragile country, they have seen that the services for refugees and displaced are the same services that also are being used by the host population. So they have seen also that the services for these people are not only for the displaced people, but even for the local population, because the health system is always, sometimes are so weak that this population are using what is being offered to the displaced people. So they can see the interest in that field. And this is why I think now more and more they are learning to know that these services are very important. But still, I think there is a lot of work, there is a lot of advocacy to do. You know, not only from the government, host government, but even from the donors to really make it a routine. Because until now, it is still not a routine. Especially the reproductive health services in emergencies is still not a routine after, you know, all these years. And there is a need for more advocacy to really improve on what we have now.
Can I just add a tiny little bit to that? Because I think, I don't want to have the misconception. I think as some women were, and obviously very desperate to be that outspoken to the international community for what their needs were early on. I mean, to get their voices heard amid all that's just amazing. But that's probably not, I mean, the picture for most of the population, where it is going to be important to give them these community-based approaches, information, education, empower them to know what their rights are and what can, what could be of benefit and help them. So those two pieces are, I think, still really important in the field now.
Mm-hmm. Yeah, we have two questions. We start in the back and then come to this gentleman, and then there's another hand over there somewhere.
I'm Dr. Halida Akhtar. I'm currently working with MSH. I'm their Global Technical Lead for Reproductive Health and Family Planning. I must compliment all the speakers for portraying the real sufferings of women and also the success of women who came here and talking about the other women who are suffering. I think we have a positive environment now, and we have seen Secretary of State Clinton to talk about women in the development agenda. And we have to hold that slogan and move women in the priority list of all the development activities. It does not have to be the last in the list of priority areas. It has to be the first one. If we talk about other conditions, other diseases, they come in the first. But I think the women's condition, women's mortality reduction, child survival, and women's development, women's empowerment, these are the agenda should come in the front line. And I think we all who are sitting here, I think we all believe in that. And I think wherever we are working, in which chair we are sitting, and which forum we are accessing to, we should raise our voice and say that women should be really in the development agenda, and what we say, we mean it. Mm-hmm. I must compliment SETPA. I'm one of the SETPA alumni, and I see that SETPA made a major contribution in bringing people from developing country and participating, allowing their participation in the ICPD. And I think that had made another big agenda. And now the ICPD recommendations have come back in the real play, and we have to hold on to that and move our, navigate our work and move on. I must compliment everybody. I just couldn't say, but compliment this effort of SETPA. Thank you very much.
Thank you very much. Yeah, hear, hear. Hey, Dan, there was a question right there in the middle.
I'm Manuel Zenik, World Bank and Peace Corps retired. There is no mention, I note, in the panelists with respect to vasectomies. I wonder if the panelists could indicate if there is any scope or hope for that in the cultures that you represent.
Vasectomy. Well, I think it has been provided in a number of refugee and IDP settings. I think in Thailand, the refugees in the camps there had access in the Thai hospitals to vasectomies. And over the years, the numbers who have taken advantage of it have increased. I think Marie Stopes has done some work in northern Uganda with the internally displaced there and these mobile clinics where long-term methods can be provided. There are some really, I think, stellar projects out there. It's just that they're not enough or done consistently enough. They need the scaling up and more consistently available in most IDP settings, for example, where they can be done.
Yeah, it is just taking off because for many years, there was some confusion between vasectomy producing impotence among men, and that has really made them a little bit resistant. But now they are understanding. It may take time, but as she say, in Thailand, they are really, among the refugees and displaced people, they are having a very significant number of vasectomy, and I'm sure that even in some other places where it is very well explained. Some men really now do not hesitate to have vasectomy, and it is very new, very new.
Tubal ligation is more where our expertise is, because in Pakistan, men and their manhood is a big issue, and vasectomy is somehow a big challenge to the manhood. The numbers is not significant enough to be quoted, but for the trend to become popular again, it will be linked directly to women empowerment, because if there is the kind of difference, inequality that exists between the genders, doesn't make any sense for the man to do anything. And for the man to share the burden or responsibility of reproductive health, women will have to raise the status of women. That's the answer.
Well, for us, I'd say we're just starting, and we're yet struggling and grappling with the few methods that we have available. We're yet to have the whole gamut of methods that are available for women. So I guess by the time we're done with that, we'll take each step, one step at a time, and then we'll see how far we can go before we can approach the issue of vasectomy.
Okay. Did I see there was another question? Yeah, go ahead. It's fine to ask too, no problem.
Well, it's not a question, or maybe it is. It's probably a very improper statement. But in response to the question you asked about disruptive times, warfare, and displaced people and so forth, where contraception might take a lower priority position, I think, on the contrary, the husband as well as the wife should be told to prepare for possibilities of rape by strangers and possibly trading the woman's sexual activities for food and so forth during these disruptive times. That is doubly important for every family that might be subjected to these conditions to have contraceptive devices on hand for the wife to use, so that the husband won't find that his wife is pregnant from a stranger and so forth.
No, I think that's an excellent response to my query, how to break through this false notion that it's a second priority. It's exactly because we see so many times that sexual violence is a result and a tool of conflict that it makes it all that much more important to do it.
I'll have a word of caution there, though. I don't think if the men, that will be a very good argument for the men to have, that you should not let your wife get pregnant by another man, and because that will suggest that it's okay for her to have sexual intercourse with a man but not get pregnant. So that probably is not a good argument in some context. Definitely to contraceptive need is a huge need, and we need to sort of, without giving any excuses, make them realize that it is important in emergency situations. Yes.
Yeah, well, I completely understand the point you're raising. I think, though, the overwhelming weight, though, comes down upon informing communities about how emergency contraception can prevent a pregnancy from a rape. So fathers, brothers, husbands, everyone know where their daughters, their sisters, everyone know what can be done to prevent further complications from a rape. I mean, generically speaking, so I don't mean going to one father and saying you need to prepare for this. I mean, educating communities so that they're aware that there's a reason to get, emergency contraception. There's a reason to get care. They have to know the benefits of it or they won't seek it. So I think informing people that, there are benefits to getting care after you've been raped to prevent further complications, even death, because women get pregnant, then they have the unsafe abortions, and then they die. And we, without a lot of statistics in these situations, we know where rape is really prevalent. That happens quite a lot without knowing how much.
That's true, but my concern is that when there is an implication of sexual misconduct, even rape, the solution that many countries, including mine, have is honor killing. Mm-hmm. So we just don't go there as an argument.
Yeah. But because I'm familiar with that and some policies, but then is it possible to make it more of a health issue, make it more of an issue for health professionals, that they know that this is a standard of care that as a health provider they should be ready to provide, and then coaching it kind of in that framework and saying it's a standard part of healthcare that you have to give, and that people need to know that they can avail themselves up to prevent these things.
Definitely.
More removing it from the individual
yes.
case that would connect to the honor killings.
Just a caution about using that argument that rape to prevent pregnancy from rape or sexual misconduct. But the contraceptive on their own for health is definitely an acceptable argument.
I just want to say here that it can be made as part of standard protocols in hospitals. For instance, anyone that's a victim of rape, apart from preventing sexually transmitted infections, giving them post-exposure prophylaxis against HIV/AIDS, then emergency contraception is also part of the package. So it becomes like it's part of the treatment, and it's not an option, provided you are a woman of reproductive age.
In the post-rape kit.
Yes.
It's part of the post-rape kit.
Yes.
Okay. Question. I think we have two more, and time to maybe why don't we get both of those together and then give our panelists a final word.
I was hoping to go back to the topic on making reproductive health a priority among governments, but not just on the international level. I was thinking more like at the national level. And I appreciated the example, for example, in Pakistan, where more collaboration between NGOs and the community and partnerships between the public and private sector are putting it in front of the government to make it a priority for the national government. And I was hoping to hear other examples where maybe national government priorities, I guess for reproductive health isn't a national government priority. If there's examples of that and examples of how communities or NGOs or grassroots level activities have helped to make it a priority at the national level.
Okay, and then we have a gentleman right down here in front, and we'll get his question and then give our panelists the final chance.
Hi, I was actually going to talk about the global gag rule, and I was just thinking that there are a lot of supporters of the gag rule here in the U.S. and in the U.S. House, and that those numbers might increase in November. And the question I have for the panel is that what are your arguments to repeal the gag rule completely, so you can you can persuade these Congress members to vote against it? Thank you.
That's a pretty tall order, but on either or both of these questions, you have some final reflections. Sandra, would you like to start?
They are tough questions. I mean, examples of community organizations who have been able to influence the government. It's kind of difficult when you're talking about, refugees are internally displaced, because the refugees, of course, are guests in the country. The displaced usually there's an issue between them and the government to begin with. The conflict is directly between them. So I don't think, I mean, there might be cases certainly, and if there was the possibility of being in a collaborative kind of partnership and doing advocacy together would be much more effective, I would think, than being a small local NGO trying to do something on your own. I mean, I know in stable development context in Thailand, for example, there are lots of cases where civil society groups, advocate, the same as we do here, and influence the government. But in the displacement context, that's probably a little bit more difficult for the reasons I mentioned. And on the other question, I think, we are in support of the move to, have the global gag rule completely ended so it can't be overturned with each administration, and with, I think, take action on our website on it.
Grace?
Yeah, I think for the gag rules, we'll just that how we have really, many of our country have really suffered during the gag rule. I was telling you about the fact that for 2 years, from 2003 to 2005 in Chad, we could not have contraceptive in our public sector hospitals. So we have suffered from that. We have seen many cases of, backyard abortion, dying young girl, very young girl, dying from that. So we'll just say that it is a question for life, question of life. You have in this country some of these places where 30% of cause of maternal mortality are due to unsafe abortion. So it's a question of life.
Global gag rule, it's a sensitive issue for US, I know. But if you look at just one example, which is of International Planned Parenthood Federation, it has member association in 180 countries. And the gag rule deprived the entire 180 countries from getting US funding in the reproductive health area. I can give you an example of Pakistan. When we had the US support, we were reaching out to 10% of the entire population. And if this setback due to gag rule had not happened, I think we could have very easily managed it up to 25. But because of the withdrawal of the US funding, we went down from 10%. So if reproductive health is an issue, then this is definitely not helping it. I think it's a very logical conclusion. And the congressman, I think that's the US citizens' job to convince them. And and I think it's a very logical argument that you can make. There are a number of studies which show that no good has come out of it, even in US itself. So pull it together, present it to them.
Well, mine is some of our governments have a lot of policies, a lot of written policies. However, when it comes to the implementation, it's an entirely different kettle of fish. And then, of course, we have a lot of these implementing partners that are working on different projects at the same time. So there may be up to 10 NGOs that are working on 10 different projects and all working independently. So perhaps if they can put their act together and address many issues at the same time and involve the communities, I'm sure they can do much more, regardless of what the government commitment is to whatever they are trying to achieve.
Okay. Margaret, I'll give you a final word. Margaret Noise.
Yeah.
Sorry, my name is Margaret Noise, and I actually was in USAID in the implementation of the global gag rule during the Bush administration. So I'd like to just clarify two things. And this is, please don't assume this is a defense of it. It's not. But, and I do have some suggestions in terms of the well, maybe not suggestions, but challenges in terms of the arguments to make. One, in the case of Chad and UNFPA, it was not the global gag rule. It was UNFPA and the work in China that affected their funding. It was not the global gag rule. It had to do with a completely different part of the legislation. Secondly, on the global gag rule, the choice of IPPF to not sign the global gag rule is what affected its funding, not the gag rule itself. It was a choice of IPPF in Bush 2 that changed the situation from the original implementation of Mexico City, when IPPF left it up to its affiliates to decide whether to sign or not. So there was a choice made, and that choice obviously affected a lot of IPPF affiliates around the world. There were a few who chose to sign, actually. I don't remember exactly which ones, but there were a few that did. That said, the folks who like the gag rule, and this was a battle fought throughout a Republican Congress and a Democratic administration in the 90s, from 1994 on, and I happened to be in Washington during that time too, the ones who like it hate IPPF. They hate them. They think they're promoting abortion. That is their issue. So just saying that all the things that you would do if you could keep your funding isn't going to change their minds. So you have to look at it, I think, differently. And how one can get that legislation that would not allow this back and forth every time you have a new administration, I don't know how you're going to do it. I really don't. In a contentious Congress and a contentious political environment, just look what's happening next door in Canada right now, where a very similar provision seems to be going into place in Canada. So, I don't know, I think take advantage of the present administration while you can, and keep looking for diverse sources of funding. That's my other very strong recommendation to everybody, because these political issues are not going to change, I'm afraid. At least as long as certain people remain in Congress. Now, if you vote near Trenton, New Jersey, I have some suggestions.
Margaret, thank you for the clarifications in terms of the record and the subtleties and the nuances in being inside AID, addressing these issues on a day-to-day basis. I'm afraid we've gone a little bit over in terms of our time, so I thank you for staying with us. Please join me in thanking our panel for this terrific discussion.